Welcome back to another episode of Single Payer Radio. Single Payer Radio is a project of Kentuckians for single payer healthcare. We are an affiliate of the Physicians for a National Health Program, Kentucky. The views and opinions expressed on Single Payer Radio are those of the speakers and not the station. I'm Mark McKinley. I'm a volunteer here with the group, and I'm going to turn this over to Dr. Mike Flynn.
Thanks, Mark. Let me begin with the usual disclaimer that any comments I make here are my personal views and do not in any way represent the views of the University of Louisville or the Department of Surgery.
Any comments that I make are those of mine and not the views of Taylor Regional Hospital nor the University of Louisville Department of Surgery.
Okay, so we have a guest speaker today, Henry Sadlo. Henry's a cardiologist, and we're going to talk about a number of cardiac issues today. So Henry went to medical school at U of L, did a residency in internal medicine and a fellowship in cardiology at Emory University. And his special interest is preventive cardiology and the cardiac CT calcium scan, which is something we're going to talk about. So Henry, welcome, and we appreciate your willingness to do this with us today. So as we have done with guest speakers in the past, we're going to give you an opportunity to make whatever comments you'd like to make about whatever aspects of cardiology you'd like to emphasize, and then the conversation will begin. So, and I'm going to ask you, though, to begin with a little bit of local history and tell us about the story of the relationship between your father and Muhammad Ali, and then we can get into all these cardiac issues.
Thank you, Mike and Jean and Mark. Thanks for having me here. And so my father came back from World War II and went to law school. And in the mid-50s, didn't have any children at that time, working as a Commonwealth prosecuting attorney. So he decided to go down to Golden Gloves boxing to volunteer because he was a boxing instructor for the Army in World War II. Well, he got down there and Joe Martin, who he didn't know, said, well, what do you do for a living? And my dad said, well, I'm an attorney. And they said, oh, you're a smart guy. We're going to make you the matchmaker. So starting in the mid-50s, my dad would pair up kids like Cassius Clay, Rudy Clay, Jimmy Ellis, Jerry Ellis, Troy Eskridge, another name. I think there was a Beeler in there, but and he kind of befriended all these young kids. And of course, some of those names everybody knows went on to become famous boxers. But when I was a child, 1963, Cassius Clay, I think he was still Cassius then. But anyway, he came out to my house on a Saturday. I was about 7, and he picked me up and drove me to my grandma's house in a 1963 pink Cadillac convertible, which I wish I had a picture of that. But over the years, they remained friends. And most recently, Ken Burns came to town because he's working on the Muhammad Ali film project, 8-hour show that's coming out in the fall on PBS. But he used many of my dad's home held videos. And so we're going to have a little spot. It'll be a great honor for my dad, who passed away in 2007 of heart disease. But he will be smiling from above when he sees his home videos used by the famous Ken Burns on this Muhammad Ali special.
Well, we'll all be looking forward to it as well. So, Henry, tell us, the floor is yours to discuss whatever cardiac issues you'd like to in order to get this program started.
Okay, Mike. Well, one thing I'll tell you, since you and I have been friends for probably 30 years, and I've known Jean recently, well-respected surgeon in Central Kentucky and done a lot for people down there, but I can be long-winded. I inherited that from my dad. So, Mike, you raise your hand whenever I'm going too long. But anyway,
right, I'll do the finger across the throat.
There you go. That'll work. So anyway, I spent the first perhaps 25 years of my cardiac career Going in the middle of the night on call, going in 3 a.m, doing an emergency heart cath, putting in a pacemaker, someone with a massive heart attack. I might even do that twice in a night, just like you gentlemen had to go in for emergency surgeries. But what I decided to do in the last bit of my career was to try to, I said it would be nice to try to prevent these events instead of just fixing the problem when it happens. Well, why can't we try to prevent some of these people from dying and having heart muscle damage? They have a heart attack. And that's when I became more focused on preventive cardiology. So, there's several different types of prevention, and I'll just mention 2 of the 3. Primordial means never let coronary disease develop. That's probably impossible genetically. But secondary prevention is when someone's already had a heart attack, had a stent, had a bypass surgery. Prevention is directed to keeping them from having a secondary event. What I've been trying to do at the University of Louisville here for a while is try to do primary prevention, try to diagnose coronary artery disease earlier, and try to do something about it to help people prevent needing a stent, needing bypass surgery, or dying of a heart attack. Unfortunately, 25% of people, approximately, their first symptom of coronary disease will be a heart attack, and maybe 20 of those die at home and never make it to the hospital.
Gene, you want to start with the first? Well, Henry, let me. I just got back from Florida, and I spent some time on a couple of beaches, and was really impressed with the size of so many people we saw on the beaches. So why don't you start off by kind of giving us a view of how do you address the issue of obesity in this country, which I guess is supposed to be around 30%, but we think it's somewhat higher. And I looked at the people walking around on the Florida beaches, and their hearts have got to work hard to push the blood around all that body mass.
Well, I agree with you, Mike. And unfortunately, here in Kentucky, I'm certain the number is higher. Probably the people that I see in my office, probably 40 to 50% are overweight. I'm somewhat overweight myself. My wife says I'm a work in progress on trying to lose a little weight. But so obesity is a big problem. What I try to do in the office when people come in, the BMI is what we look at. 20 to 25 BMI is normal. 25 to 30 is overweight. 30 to 40 is obese. And then if you're over 40, that's morbidly obese. And probably, 10% of my patients are in the morbidly obese. And so I try to focus on having them work on the American Heart Association Healthy Heart Diet. And then I also, a lot of them aren't exercising. They've retired, they're older, they might have some back problems, and they just decide they're not going to do any exercise. So the American Heart Association has a specific recommendation of getting 150 minutes per week of moderate intensity aerobics. That would be anything equivalent to walking 18 to 20-minute mile. And so whether you do elliptical, whether you swim, whether you ride an exercise bike, doesn't matter what you do as long as you get that time in. What I try to do 3 mile up to 5 mile walks every Saturday and Sunday. And I try to get a couple of those events in over the weekend. So if I can get at least 40 minutes of moderate intensity aerobics in 4 times a week, I meet the goal. So aerobic activity is a key. Now, the problem with the obesity, it's very hard, even if I spend time talking about it, and I do, and my patients know that. A couple of things that I do that I think are helpful. When someone leaves the office and is going to come back to see me in a year, I set a weight goal for them. And whatever their weight is, if they're significantly overweight, I'll tell them to try to lose 1.5 pounds a month. So let's say if they come in at 250, I'll tell them to come in at 232 pounds next year. And to remind them, I'll write that on their appointment card, or one of my staff will. So they've got something they can look at once a month as a target to try to lose weight. And I had a gentleman the other day that weighed 317 pounds a year ago, and he came in at 300. And I patted him on the back and congratulated him. I said, that's a great step. Let's keep going. Let's don't backslide. But as you, Mike, and Gene both know, a lot of people just can't do it or have a hard time doing it. And then I try to tell them to join Weight Watchers. And then if we have to, we send them to one of our bariatric surgeon friends, because when you have morbid obesity, you get all the bad things: hypertension, hyperlipidemia, hyperglycemia, metabolic syndrome. Not good.
Well, years ago, and we're going back to probably back to the 80s, I wrote a couple of papers on nutrition in patients with head and neck cancer. And these folks, as opposed to being obese, were undernourished. And the person I wrote this with was a nutritionist. She was very good. And one of the issues issues that she had in terms of the people carrying all this weight around is soft drinks. And when I would ride on the elevator in a medical office building or in the hospital, you would see a significant number of large people on the elevators with this huge container and a straw sticking out of it, and they're constantly sipping on a sugar solution. I noticed the same thing down on the beaches in Florida. These very large people, they all had this big container with a straw sticking out of it and constantly sipping on it. And that's a really, how do you, is that an issue that you get into? Because she would, this was a long time ago, but I don't think anything's changed, is that this is just a constant stimulation to the pancreas. You drink the sugar gets into your blood, stimulates your pancreas, fire off some insulin, and it continues and propagates this sense of hunger, and they keep sipping and sipping and sipping and putting on weight.
Well, one of the things, obviously this would take money, but if every cardiologist, endocrinologist, internist had a dietitian in their office, where every patient that was overweight, once they finished seeing the physician, could even have 10 minutes with the dietitian, they would probably point out some of those things that you very clearly realize are a key issue: too much sugar, soft drinks, and things like that. But I think that would be helpful. And we can write for a dietary consult, but that doesn't happen very often. What I do, I tell people there's all kinds of books and things written out there. I tell them to go to the American Heart Association website. If someone really wants to get serious in reverse heart disease, Dr. Dean Ornish has been working on it for 45 years, and he has a book called The Spectrum. So he's a vegan, and he has a 0 coronary calcium score. He told me so when I met him once. But the spectrum means if you can't do what he does, even if you get close to it, if you do 70 or 80% of what he recommends, vegetarian diet, you'll do a lot better than you're doing now. So those are just some thoughts on that.
Dr. Sadlo, I know you've been interested in the coronary calcium imaging. When do you order a test? Let's say you have someone comes in who's morbidly obese, they're 40 years old, they're not exercising. When do you start doing some imaging to determine their coronary artery status?
That's a great question, and the answer is different for females and males. So probably the earliest I would typically order a coronary calcium scan on would be a 40-year-old male or a 45-year-old female, with a few exceptions. If they're a heavy smoker or a childhood diabetic, then you might do it earlier. The problem with the coronary calcium scan, so let me tell people what that does. So without any injections of dye, you can lay on a CAT scan table, and in 90 seconds, just do a limited CAT scan of the chest over the heart. And if someone has plaque in their arteries that has been there for a while, developed plaque because of the inflammation, builds up calcium deposits. So we can see that on a CAT scan. Now, the problem why this test doesn't work for younger people, Gene, a heavy smoker that you might have seen for a hernia repair that's 35 down in your practice years ago, if they might have soft, non-calcified plaque that's very angry and inflamed, and that might rupture post-op or something like that. So that you can't pick up with a simple non-invasive $99 coronary calcium scan. But once you get older, that plaque does calcify. So in men over 40, women over 45 to 50. One thing that where it's most helpful, I find, is let's say in 1995, when I was early into my practice, someone would come into me and tell me it was horrible. My brother just dropped over dead of a heart attack with no warning. And I'm 50 years old. He was 52, and I'm petrified. So back in those years, I would order a nuclear stress test. Unfortunately, probably gave them more radiation than in retrospect I would want them to have. But it was the best non-invasive test, and that was the best way for me to reassure them, or at least give them some confidence that their heart was okay. But unfortunately, a blockage won't be abnormal until it's about 70% narrowed. So I probably told a lot of people that had triple vessel moderate coronary disease that they were fine, and they weren't. Well, nowadays, the calcium scan can get around that. It can at least tell you if you have coronary disease. And if you do, that's a great motivator to work on the risk factors to get them to lose weight, eat better, exercise, get on a statin, and those type things.
What if somebody has had a stent placed, let's say 4 years ago? Do you have any use for the calcium scan for follow-up of those patients?
Well, the calcium scan, unfortunately, is a screening test. So once you've had a heart attack and a heart cath, once you've had bypass, once you've had a stent, then that test is not appropriate in general. There are a few exceptions. I've had a few patients that had a single vessel lesion in the left anterior descending that had a stent 25 years ago, and their other two vessels were reported as totally normal. And occasionally I will order that, rarely, but occasionally, to check out the right coronary artery and the circumflex. But in general, calcium scanning should not be utilized for people with stents. Those people would need a functional test, stress echo, stress nuclear, or perhaps what's called a CT angiogram. That's where you use a CAT scan, but you give them an injection, and that's a lot more radiation, about 15 times the radiation of a single screening calcium scan. And I should mention that the radiation that you get with a calcium scan is about 1 millisievert, which would mean not much to anybody else but radiologists, but it's equivalent to a mammogram. So if I've got a 50-year-old female that's getting a mammogram every year, I say, this is about the same amount of radiation to tell you whether you've got what your sister had. Sister had a heart attack. So that's where it's just very helpful.
Henry, I listened to a bunch of podcasts so that as a retired head and neck surgeon, I could ask intelligent questions. One of the podcasts I listened to was a while ago. I can't remember all the details, but I came away with the impression that cardiac disease is different in men than women. And I don't remember all the specifics, but maybe you could enlighten me on that, because I was a little confused about exactly what they meant. It was a podcast that was probably focused for cardiologists, not for head and neck surgeons.
Well, there are differences, definitely. And probably the biggest difference is women are more likely to have atypical symptoms than men are. It would be lovely if everybody that developed coronary disease would have the classic heaviness and pressure right in the center of the chest. But in women, they're more likely to have atypical symptoms such as nausea, uncomfortable feeling, not necessarily pain. They might have shortness of breath and no chest pain. Sometimes they have pain in the left shoulder or jaw, just much more common in females to have atypical pain. So when someone's complaining of pain to me in the office, a female that might be 50 years old, if it's atypical, for me to order an expensive stress test, sometimes we do that, but if I can get them to pay out of pocket $99 for a screening coronary calcium scan, if they get a score of 0, then I might tell them to look at other etiologies through their primary care or internist, maybe esophageal etiologies, pulmonary etiologies. On the other hand, if they come in with a score of 1,000, then they're in the right place, and I need to get to work and see if they need a heart cath or a stress test, and also get on the risk factor modification. So, and then also women have, in general, may have smaller coronary arteries. So the stents and things that we put in some women with diffuse small vessel disease, they don't do as well with bypass surgery or stenting, but aggressive medical therapy will help them.
One of the other podcasts that I listened to, and I was kind of surprised, was one that addressed the issue of cardiac disease in high intensity athletes and marathon runners, people who just were, really, really aggressive cyclists and, other athletes like that. And was really surprised that apparently if these people are stressing their hearts, and once they get into their 50s, 60s, and 70s, apparently they have a fair amount of heart disease, which surprised me, because I would have thought these were the people that would be the healthiest. So I mean, the question really has to do about exercise. You mentioned moderate exercise. I've got a Airdyne bicycle in one of our rooms, and I sit on that thing and pump for 20, 30 minutes at a time. And what I used to do is I did do this, and then in the last 5 minutes, I'd really be pushing it. Now, is that not, if you had somebody with an arrhythmia or some sort of mild degree of cardiac disease, where do you draw the line? Is it not a sensible thing to do to try to either run and walk and run, or just start doing varying speeds on a stationary bicycle or on a bicycle, or even swim slow laps and fast laps? So sort of where is the sweet spot in exercise for people as they get older?
Well, that's a great question, and I'll preface that by saying I'm not a sports medicine cardiologist, so I don't know all the answers, but I will tell you I've seen some reports and some papers where people that overexercise all their lives, keep running marathons into their 50s or 60s, you can develop some myocardial fibrosis, which I was quite surprised by that. And it's interesting. You would think that people that got all the aerobic activity, usually their blood pressures are better, their glucose tolerance is better. I mean, I think that's pretty much proven. Vigorous exercise helps with lipid management too. But I was kind of surprised to see that it didn't necessarily reduce the amount of coronary plaque that people had. So, I'm not sure. I think as you age, maybe more to protect the musculoskeletal system, but I don't know that it's a good idea to keep pounding it in your 50s and 60s. I will say that a good friend of mine who's a professor at University of Louisville, I ran my first mini marathon with him in 1978, and I ran about 15 total. But as I got busy, I quit doing that older in life. And after he ran his 30th, he came to me and I helped him do preoperative clearance for a hip surgery. So I don't know if that answers totally your question, but I think there's some concern out there that high intensity exercise for longer periods of time may have some negative, which I was surprised. as you were of that. I don't think the final answer is out there yet, but there are concerns that over-exercising may not be so good for the heart.
What about moderate exercise?
Moderate is fine. In fact, that's the general recommendation. So, I think a light jog, if you like doing it. Mike and I, and Gene, you probably know this fellow too, but Dr. David Nightingale, my good friend who inspired me to kind of start my little walking group. He told me he ran his last mini marathon at 70, and he won a Triple Crown in his early 70s. And he's not going to be 90 next month. David, I hope if you're listening, you won't be mind me telling your age, but he's in spectacular health. So, he did that, and he's a good example of someone who looks great and thinks great, feels great at 90. So maybe some of those articles that Mike and I saw were wrong.
And you know what he took up after he retired?
I'll let you tell that story, Mike.
Yeah, he just started jumping out of airplanes.
Yeah, I'm going on record saying, on record saying that I do not recommend that. But,
yeah, okay.
Well, I was a flight surgeon in a C-130 outfit. When we had paratroopers in the plane, I always stayed up in the cockpit.
Yes. And Dr. Hiram Polk, Gene, told me that you were a very smart surgeon. That's why you stayed in the cockpit and saved your spine from spine trauma. Yeah.
Well, I think the sweet spot or the issue about saying, well, moderate exercise. I think moderate exercise is different things for different people, and then trying to determine. We've got a tandem and we ride in Cherokee Park. And what we've generally done is ride that loop 3 times. We live off Cherokee Park, so that's 3 hills and 1 more hill to go back up the Cochrane Hill to get back to our house. And so, that's the moderate exercise is the flat part, but when you're going up the hill, that's not moderate exercise. That's really pushing it. So I guess I'm wondering, as the numbers start adding up on my age, whether I ought to be modifying what I'm doing with that tandem in the park there.
Well, I don't know if a little bit here and there of high intensity is a problem. Now it would be different if you have known significant heart disease. On those people that I diagnose significant heart disease, I usually put them in a cardiac rehab program where they have a cardiac monitor on. So if they do want to push it like you're pushing it up a hill, they can at least see what it looks like on a cardiac monitor in front of a nurse that can defibrillate them if they push it too much, But anyway,
well, there's not a lot of those out on Cherokee Park.
No, there's
when
not.
you get up to Hogan's Fountain.
That's right. But the one thing I would say is that the exercise, I think it has to be kind of continuous. So some of their dog out. Well, the dog stops every 100 feet. That's better than sitting on your couch, but it's not as good as going out and just walking, at a moderately brisk pace for 60 minutes, or 30 minutes, take a sip of water. And, so that's what I try to do. I try to get 40 to 60 minutes of moderately brisk paced walking, not race walking, not 15-minute miles, but 18 to 20-minute miles. And, and then the problem is a lot of people have back problems, knee problems, hip problems. And one of the things that I've learned about is there's a program on KET, I think it's KET2 here in Louisville. And at 7:30 every morning, this lady gets on there and does a program called Sit to Be Fit, where she sits in a chair and she does 30 minutes of aerobic exercise with the upper body. And I at least try to tell my patients to do that if they can't get out and move with their hips and back problems.
Well, we occasionally see young people in their 20s who have myocardial infarctions. And I always when that happens, think they're probably on cocaine. Am I correct?
Well, yeah, yes and no. I remember some of the early autopsy reports. I think William Roberts, Bill Roberts, was the editor of the American, I think it's American Heart Journal, but famous pathologist down in Texas. They found soft, streaky plaques in 27-year-olds that they did autopsies on in Vietnam that came back, and they were shocked that 27-year-olds would already have plaque. But and those are usually the heavy smokers or familial hypercholesterolemia or horrible genetics. But obviously, cocaine is very dangerous to the heart. It can cause coronary vasospasm. So I think if you got somebody in their 20s, you got to figure out if they're not doing cocaine, they've got one of those other severe premature problems that need to be diagnosed. Because nowadays we've got a whole armamentarium of medications that we can put them on, where we didn't have that 30 years ago.
Henry, where does childhood obesity fit into this? Because when I grew up, there just weren't very many heavy kids, and again, to go back to the Florida beaches of last week, there's a lot of them around, and now we know they have more. They have hypertension, they get diabetes. I mean, I'm talking about young kids. These are adolescents. So well, I'm assuming that the heart issue is just the same earlier incidents, and as along with the hypertension and the diabetes.
Well, I think because of that, Mike, I agree with you. And I think, unfortunately, we're going to be seeing more coronary disease, more issues because of the obesity. I think if you don't get to these kids, in the early grades 1 through 8, if you don't get to them by the time they get high school, the battle may be lost. So hopefully someone will put some funding into really making a push. The schools may need more dietitians to help instruct these kids, and somebody needs to be watching over what's going into the machines where you can put $1 in and get something out that may not be healthy for you. So, but I agree, childhood obesity is a big problem. What I think would be interesting is to take football programs from some of the local high schools in the 70s and the 80s and look at the body weights of every player, and then match that with the current high school football programs in the state, and see what the difference is. I bet the weights would be significantly higher, as you've observed.
One of the other issues that I learned about in my my podcast listening was it was a similar to that the impression that cardiac disease is different in men and women. Was also another one that seemed to suggest that cardiac disease is different in different ethnic groups as well. So again, is that if that's a real issue, maybe you could make some comments on that. And is the black population different than the Hispanics and the whites?
Yes.
Or Asians?
Yep. So that's an excellent question. And what looked at that was actually a large scale coronary calcium program called the MESA study, MESA, multi-ethnic study of atherosclerosis. And Roger Blumenthal up at Johns Hopkins, who's a pioneer of preventive cardiology, he was one of the main people, was with the big group that started this. But and then other groups have looked into it. So the highest incidence of coronary disease is actually in the South Asian population. People in the area around India have the highest incidence of coronary artery disease on screening scans. Next is Caucasian, then African American, and then the least is East Asians, Japan, areas around there. They have the least amount of coronary disease. And, as far as that's, just a genetic thing that they've discovered. I think the African-American population, They still definitely have coronary disease, but they might be at more risk for complications of hypertension, such as cardiomyopathy and hypertensive heart disease. Perhaps that's a bigger problem in that ethnic population.
What should we do about all these obese people, particularly children and teenagers? It just seems to be totally out of control. I've observed the same thing when I moved back to Campbellsville. I've spent a significant amount of my time in the summer on Green River Reservoir. And in the early 80s, there were no obese people getting on boats. And now you got to ask yourself, is this boat going to swamp or not?
Yeah, I think that as physicians, we need to make sure, everybody's rushed. Everybody needs to see X number of more patients. And I think it's not responsible if a doctor spends 10 minutes with a patient on a follow-up visit and doesn't spend any time talking about the elephant in the room to, really bring that out. Because it is important. And a lot of times, I would say at least 10 to 20% of my patients, they'll come back in the next year and they will say that, I'm glad you talked to me. One gentleman came in and I told him to lose 18 pounds and he'd lost 30. And so I told him what I would do. I would take his card and scratch his name off it and put it on my wall of fame and leave it up there for a couple of weeks to show where he went from 280 pounds to 250. So you just have to spend time with patients. You have to talk to them about it in a non-angry, non-threatening kind of way. And you need to convince them that you're not doing this for your benefit. You're trying to help them. And it'd be nice if we had some safer medicines for weight loss, but there is no pill. And that when I give people from the American Heart Association, I give them a 2-page handout and it says, you need to burn off more calories than you put in, and the American Heart Association has an 8-page website. So there's more information for people who really get the message on their website.
Let's talk a little bit about access to care. Gene and I have actually written an article for Louisville Medicine on rural health and issues related to that. And we've actually done a program on that. In rural communities all over the country, for an assortment of reasons, there aren't a lot of specialists. And so the responsibility for dealing with a lot of cardiac issues, as well as some endocrine issues, managing diabetes, falls in the laps of primary care physicians. I don't mean to criticize them, but you got some thoughts about ways that we can improve access to the specialist care in rural parts of this country. Australia, for example, has got a section in its government on rural medicine, on providing surgeons and specialists to parts of Australia that are really way out back and rural. We don't seem to be doing that in this country. You got any thoughts about where that's going to end up? It seems to me 10 years from now, it's going to be worse than it is now. Gene, you live out there, so I wonder what your thoughts are before we let Henry take a crack at it.
We've done a pretty good job in our relationship with specializations, particularly in Louisville, for example, in cardiology. We have 2 cardiologists that are in Campbellsville 3 days a week. And if we have an incident in the middle of the night or on a weekend, the cardiologists are available. And if they've had a MI, we ship them up usually to Jewish Hospital and they get taken care of. If it's just somebody we want to watch, they will consult the next day. And it's worked out extremely well for us. We've done the same thing in cancer. We have our own cancer program, and we have affiliation with the Brown Cancer Center and the Cancer Center at the University of Kentucky. And we refer patients back and forth. Not only do we send patients to them, but they send patients to us. And we've done a similar thing with our trauma care. So I think that type of situation and relationship between the physicians in the urban area and the rural area is very important. I've made great effort through the last 40 plus years to maintain a relationship with the Department of Surgery, and it's been of great benefit. I can call somebody up and they'll give me advice, or if I need a patient sent up for specialized care, that's worked really quite well.
Well, Gene, a couple of points on that. First of all, I don't know if you're allowed to say names, but I know the two gentlemen that go down to Campbellsville, Taylor County, and they're both great human beings in addition to being great cardiologists. So, and they've dedicated themselves to your city down there for 25, maybe 30 years. So my hat's off to those two. And as you probably know, Gene, I ran a clinic in Greensburg, Kentucky, 1 day a week for about a decade, and then a clinic down in Hardinsburg, Kentucky, for about 20 years, 1 day a week. And I enjoyed that. I like traveling, and the people were very appreciative. But Mike, to your point, I think there is going to be, we need more. And I think one of my thoughts would be, when people do internal medicine, they do 3 years of various things. I think we might need to get to a point where we say, okay, you do 2 years of internal medicine, and we're going to have you do your third year specializing in cardiology. Not procedures, not stents or heart catheterization, but to learn how to do stress tests, read echoes, and do office cardiology. And the same with gastroenterology, the basic simple procedures. So, if you took a 3-year internal medicine program, you might even be able to do it with family medicine. And then the last 6 months or the last 12 months, you kind of did all specialty training. I think that would be one way to perhaps fill that need, because I think there's going to be a big shortage of cardiologists in the future, personally.
Mark?
Yeah, just a question and or a comment about, are we evolving even more into a fast food nation, and as opposed to where we were back in the 70s? It's the pace of life, mom and dads are working, the time factor. You talk about access to healthcare, access to healthy, fresh food, vegetables. I know there was a story on NPR this week that they were talking to Army recruiters, and the problems that, and many of those, Gene, were in rural areas, that they had to work with potential recruits to get, because of the overweight and obesity, that they couldn't qualify to get into the service. So they were almost like, these recruiters were almost like personal trainers to some of their recruits to get them to a point where they would qualify. But just a comment, and I thought I'd read some time ago that some of the early community health centers, maybe in Mississippi, where the doctors there were prescribing food. I mean, they were able to prescribe healthy foods to their patients coming in, because back then of malnutrition issues. So, comments?
Well, I'd hate to be a recruiter recruiting some of the folks that I saw walking around the beach in Florida. Henry, all right. So let's get into some specifics here. If you had to tell me, say, 5 food substances that I should avoid because they're not good for my heart. I mean, I'm assuming something like processed meats. What would the top 5 be that you would suggest that you either eliminate from your diet or just have minimal amounts?
So I would tell you to walk into any of your local convenience stores, gas stores. I'm not going to mention any names. And everything you see in there, you should avoid. It's all processed. It's all fructose. It's all high sugars, heavy salt. And, I'm friends with Dr. Brad Stanford, who has spent a life with health and nutrition, and he's written books on it. You want to stick with the leafy green stuffs. You want to stick with vegetables, meats, lean meats. I tell my patients that aren't vegetarians that, if you treat yourself once a month to something that probably isn't good for your heart, once a month is okay. But if you do it 4 or 5 times a week, you're going to pay for it. So all the processed stuff. When I look at all the cupcakes and all that stuff, potato chips and everything you see in there when you go into a convenience store, if you have that every now and then, and I have some of that every now and then, it's pretty rare, but vegetables, lean protein, that's the way to go.
Let's talk a little bit about fructose. How did fructose become a problem during our lifetime?
Mike, I'll let you take that one because I'm not a dietary expert. I just know it's bad for you.
Okay, didn't one in the late 70s we got all concerned about lipids, and then we started eating less fats, and a lot of the commercial food industry started putting fructose into food products to make it more delicious, particularly soft drinks, etc.
I think that's a huge problem, and I think some of the people that make food products have realized that, and I think they're trying to drift away on that. And Gene, you brought up the word lipids, and I thought I'd at least mention to people that you want to know, over, I don't know, probably over 30 should know what their LDL cholesterol is, because of all the different lipid numbers that are measured. The LDL is critical to slowing down plaque buildup, and the new guideline is it should be less than 100. And if you have coronary disease, your LDL cholesterol, I tell my patients, it's like the speed limit on the interstate. You want it less than 70. For the European Association of Cardiology has already recommended LDLs less than 50 for diabetic patients with coronary disease. So that's what we need to do. Get rid of that high fructose stuff, all the processed foods, processed meats, and try to get that LDL cholesterol down. And people that have genetic coronary disease connections like I do, you typically have to get on a statin to do that. Red yeast rice won't quite do it for you.
Are there different cardiac disease incidences in different parts of this country? California versus Washington State versus Iowa versus Maine or Mississippi?
Absolutely. And in the southern states is the biggest heart belt of heart attacks and strokes. And, so the American Heart Association in those areas are trying to be very active, but probably the lower incidences may be places like Colorado, Minnesota, some of the West Coast places. So that is correct. There is needs to be a bigger focus in certain areas.
How much of an issue has the pandemic been in terms of the frequency of cardiac disease? I mean, people seem to be, they're staying home working from home. I got the impression, I don't know this, but they tend to, eating different things. People seem to be gaining weight. Again, this isn't something I have any direct knowledge about. These are little bits and pieces you pick up from reading a newspaper or listening to the news. And so I guess the question is, so much of everything, home life, stress, mental illness have all been affected by this pandemic. Where does cardiology or cardiac disease fit into that equation?
Well, the incidence is going up from the last year. It was not good for cardiology for two reasons. I would say that on being a frontline cardiology provider, that probably 2/3 of my patients gained anywhere from 5 to 15 pounds last year, just because they weren't doing as much exercise. They might have had a gym membership at the YMCA where they gave it up for a year, and they didn't watch their diet. Sitting around at home more, working from home, you might be closer to a refrigerator. So I think it's an issue, and we probably won't see the effects from this last COVID year until 5 or 10 years. You might see a spike in 5 or 10 years.
Well, one of the, I guess, I don't know if this is a fair question for you, but, we are sponsored by the Kentuckians for single payer. And that's an issue about promoting a form of health insurance that's provided by the government. Canada has a single payer system so that anyone who's got a medical problem can go see whatever they see, and that individual physician then sends a bill to the province, and the province pays the bill. They don't have to deal with 1,000 and different insurance companies and Medicare and Medicaid, or underinsured, no insured. It's different. Do you had some thoughts about it? Just suppose we had a single payer system in this country. How would that affect your ability to manage cardiac disease, maybe as an individual in your practice? And then in a broader sense, how would that affect the management of a cardiac disease in the population at large, where you've got, in this country, I don't know, there's 80 million people who are either uninsured or underinsured. And again, I don't know if this is a real fair question. We're getting, go ahead, Henry.
I think it's a reasonable question to ask. I'll preface this by saying I haven't studied the politics of medicine or insurance well enough to say I'm that informed, but it is a big problem. And I'll give you an example. In my office, there's a brand new medication for heart failure called Entresto. And if you got really good insurance, a patient of mine was from Fort Knox, retired military. He has TRICARE for life. He should be able to get this, but a lot of my patients can't get it. And, that's a big obstacle. And the blood thinners, the anticoagulants, if you don't have good insurance, if you haven't paid for good insurance, you're stuck with warfarin. And, these other medicines cost $300-400 a month. So, I mean, you bring out the point that that's a huge problem. Even with private insurances, I heard a radio show today where one of the local morning DJs was complaining because he has private insurance, but he's complaining if he wants to go see someone, he's got to make a phone call and see if that provider is on his list. So even though he's paying big money for private insurance, even he doesn't have the freedom to see who he'd like. So the problem is there, Mike. The solution is complex for people more sophisticated. I'm going to keep taking care of people with heart attacks and let someone who's sophisticated like you and Gene figure that out.
Well, I don't think the solution is complex at all. I think the solution is very simple. It is, to have a single payer system in this country. What's complex is the process of the likelihood or the probability of getting there anytime soon. We've talked about this on multiple occasions. Gene and I were talking to it about it before we started this show today.
Well, we spend about $3.6 trillion on healthcare in this country. The interesting part is about a third of that is totally wasted, that no one else spends. For example, advertising. We're the only country in the world that advertises doctors, hospitals, drug, etc. And all those expensive medicines you were just talking about are advertised on TV, and but yet most people can't afford them. The for-profit insurance companies are making huge amount of money, and they're getting more and more involved into care and more involved into government insurance. For example, they're administering more Medicaid in the state of Kentucky. They're administering most of the Medicaid plans. The same thing is happening in Medicare. So we've got a problem. If we could just eliminate a third of that amount of money that's wasted, we might be able to make some progress.
Henry, we're just about out of time. I would like to thank you for coming on. This was an interesting, informative program. Do you want to make any last minute comments before we pull the plug on one?
Yes,
minute left.
Yes, get your exercise. Try to make an effort to eat healthier on your diet. And if you have cardiac symptoms, chest pain, unusual things in your chest, see your primary care and make sure you get attention to it. And then for those with family history of coronary disease or a lot of the risk factors, hyperlipidemia, hyperglycemia, hypertension, smoking, or family history is the biggie there. If you have any of those 5 risk factors, if you're old enough, think about a coronary calcium scan. But to stay healthy and say your prayers and just keep moving.
All right. Thanks again,
All right.
Henry, and you do the same.
Thank you.
Okay,
you.
thanks everyone. For more information, you can go to kyhealthcare.org. That's the website for Kentuckians for Single Payer Healthcare. You can also follow the group on Facebook. And I think Kay or Harriet also have got us with some other social media. So thanks again, everyone.